Good people don't smoke marijuana.
I've known Larry for a long time.
Quiet, numbskulls, I'm broadcasting.
This is the Medical Marijuana Radio Show with Larry Love. All love. I got something here for you and me. Oh yeah, it's a medical marijuana. Whoa, whoa. I got something here for you and me. Oh yeah, it's a medical marijuana. Whoa, whoa, whoa.
Hello everybody, welcome to another edition of Medical Marijuana Radio. This week we have Dr. David Ostrow, and we will be talking about use of cannabis therapeutically. And it was a very interesting information-full episode for us here. Don't forget my Friday and Saturday night show on Clubhouse. It's Late Night with Larawana. Every Friday night and Saturday night at 9 p.m. on the West Coast and midnight on the East Coast. So right now, here is Dr. David Ostrow.
This is the Medical Marijuana Radio Show with Larry Love. All love.
Today we have Dr. David Ostrow, who is an MD, and David is an advocate for therapeutic use of cannabinoids and other plant-derived medications in the prevention and treatment. So, David, welcome to Medical Marijuana Radio. Thank you for joining us today.
Thank you for having me here.
So, you've been a MD for a very long time. What brought you to cannabis use as a treatment and therapy?
I ended up being drafted into the HIV/AIDS epidemic response because of my establishing the first, co-establishing the first gay community clinic in the United States, where we proved that hepatitis B was a sexually transmitted disease, and then we did the hepatitis B vaccine trials among gay men. That vaccine having been approved in 1981, just as the first cases of opportunistic infections and Kaposi sarcoma were being reported to the CDC. So the vaccine, having been tested in gay men and also produced from the blood of gay men who had acute hepatitis and high titers of the virus in their blood, was pretty much dead on arrival. Because no one knew what was causing HIV, and nobody wanted to take a vaccine made from the blood of one of the major risk groups there. Eventually, Merck pioneered the development of genetic recombination techniques to manufacture the hepatitis surface antigen in yeast, and that became a standard antigen and vaccine production.
Sure. So this was in the early 80s, right?
This was in 81, 82.
But it took till like 96 for Dennis Perrone and Jack Herer and Brownie Mary and all those people in Northern California to show that this was going to be a medicine that would help AIDS patients. So that's 15 years.
But long before that, those same people were giving out cannabis cookies, marijuana brownies in the AIDS ward at San Francisco General, et cetera. So the community recognized it. And so in my writings on this, I say this is a patient propelled revolution in medicine that science has to catch up with and medicine has to catch up with, rather than the other way around. And even though it took till 96 until the law was passed in California, medical cannabis was a thriving proposition throughout the 80s, beginning with AIDS patients and so forth. And I was seeing the first AIDS patients at both the Howard Brown Clinic and my work at the Chicago Lakeside VA, and they were telling me about their use of cannabis for the pain and the anorexia and the weight loss and so forth. So that piqued my interest. And so when we started the MAX study, I delved into what the role of different recreational drugs that gay men used in that study, including myself. And saw that, yes, indeed, there was no evidence as the study went on that cannabis use had any negative effect either on the health or the transmission of the virus. But three other drugs did. Stimulants, particularly methamphetamine, poppers or volatile nitrites, and erectile dysfunction drugs. I eventually showed that use of those three drugs were associated with the majority of new infections in the mid 80s to mid 90s among the 7,000 to 10,000 people participating in the MAX. So, when I first submitted that paper, they came back and said, "What about cannabis?" I said, "Well, every time we put it into the equation, it doesn't show as important." So we redid the analyses and found that not only it didn't contribute, it might have even been protective in some cases. Smokers tended to have of cannabis tended to have higher T cell counts for a while, but it was hard to dissociate the effects of smoking on the lungs and inflammation there and so forth. It was this really a particular effect. It was just an elevation of white cell counts due to nonspecific inflammation and so forth.
Do we know now what cannabis does to the T cell count now that it's 40 years later?
No, because people keep thinking, well, like for example, you don't want to talk about COVID, but as soon as COVID, the severe COVID or long COVID, whatever, was determined to be probably a autoimmune, disease with cytokine storm, was like, well, then some cannabinoids should be a treatment or a prevention for that, because they can diminish pro-inflammatory cytokine production. But that's a very simplistic thing. And just like in HIV, cannabinoids are very weak compared to specific antiviral drugs in either case. I mean, they're best complementary for pain and side effects of the drugs.
I believe the University of North Carolina, is doing some kind of a study with cannabis and the cytokine storm. So that should be interesting, to see what happens with that. But, flashing back again to the 80s, and at the same time that people were using cannabis to help them, with AIDS and their, the anorexia and getting them to eat and pain and so forth. We've had, a U.S. patent 6630507 that said there's so much medicinal value to this. At the same time, it's a Schedule 1, right, that says there's no medicinal value. And it's taken all these years. I mean, we're very close to either changing that schedule or dropping it from the schedule in 2021. But, that's a long time that's taken that scholars like yourself have read, 6630507, where it says that it's good for Alzheimer's and Huntington's and Parkinson's and just a slew of all kinds of medical value, actually.
Well, as much as I agree with you, that reasoning ignores the fact that there is still ongoing an enormous disinformation and propaganda campaign to prop up prohibition. Okay.
So who's behind that?
That is an industry in and of itself.
Sure.
And if you follow the money, most of the people who are against taking cannabis out of the schedule or lowering it so it can be used therapeutically and researched appropriately, have a financial and, as we saw during the last presidential term, political benefit to doing it. Recently, some group published an article about who were the major sources of misinformation on the net about vaccines, and all of them turn out to be people who use that to the anti-vaccine conspiracy movement to sell supplements and other things, to make millions of dollars. So if people can be persuaded from using federally authorized drugs, then you have an easier time of selling them whatever your particular snake oil is.
So, it's interesting that the religious right is sort of the ones that are anti-vaxxers. And of course, and they've been anti-cannabis as well. But, I interviewed a rabbi, a couple months ago, and, there are some references in the Bible in regard to cannabis or whatever they called it back then. It was many different names. I asked him bluntly, was the burning bush possibly cannabis? And he seemed to think that no, it wasn't. But again, there's so much misinformation out there. Kevin Sabet and Patrick Kennedy have that SAM group that is just constantly denying.
And of course, that they are federally supported by monies that are skimmed off of the anti-opioid appropriations, a system that was set up between Sabet and Sessions when he was Attorney General. So our own anti-opioid funding to states and other impacted areas is being skimmed to support the prohibition propaganda that people like Sabet, I think, is like the worst example of that.
Yeah, he's just looking for a payday. He doesn't even really look convincing about anything he says,
right.
Actually.
But any article, but that's the problem. There's this dual standard in medical publications in the United States. Any article highlighting some negative aspect of cannabis use, even if it's old disproved wine in new bottles, is accepted for publication without question. Whereas when we try to publish articles about the positive effects, they say, where's the double-blinded placebo-controlled trials to do that, and blah, blah, blah. And so there's this vicious cycle, this catch-22 of getting the evidence out there and accepted.
So David, there's a big problem, as you know, because we talked a little bit before we got started here, is that they've been unable to do real studies all this time. Okay, they were just bullshit. They were using cannabis from the federal grow at Ole Miss, and it was crap, and we couldn't do really great studies.
And even to get that took Sue Sisley 15 years.
Right. And finally, like this year is like the first year she's going to be able to really do something important.
Well, that's still debatable because where we read in one place that she's one of the people in line to get an award from NIDA, from DEA to produce for research. DEA still hasn't, published the rules, and they've hinted that they're going to take control of anything produced privately, and they will determine still who gets it for research.
Well,
so
speaking of,
I don't think we're yet there, and that's why I'm pushing still, because even though you can't point to a large-scale double-blind study, there's hundreds of practice-based observational research out there, and if we, if a study design can be gotten out there where clinicians and patients collect their data in a systemized way and it's combined, then we can actually make a valid comparison of the benefits and risks of cannabis versus the FDA-approved opioids and their their partial antagonism.
So NIDA and the early government research was, they told them, go find what's bad about cannabis. We got to bring out what's bad about cannabis. So all these years later, do you think Nora Volkov is like coming around now a little bit, or do you think she's still on the same track?
I got to know Nora very well because her agency funded most of my research on recreational drugs and so forth. And while they didn't censor it, every time I tried to bring up with her how their monopoly on production of cannabis, something I was alerted to by Rick Doblin very early on in my advocacy as a key issue, she would say very clearly to me, David, I cannot discuss this with you without others present, some within my institute and others outside my institute. So acknowledging the fact that to maintain her role as a director of an institute, she has to follow the party line. And the party line for all federal employees still is that cannabis is a Schedule 1 drug. And until that changes, there will be no change in the research priorities of organizations like that.
Where does her personal ethics come in? You know, as a physician, as you know, a researcher. I'm not sure what her doctorate is in or anything, but you know, at what point when she's seeing positive stuff does she say, you know, listen, we have to talk about this now? You know, I mean, she's holding that party line, like you say, but that's again to have a paying job. It sounds like Kevin Sabet and those people.
Well, because people like her can convince themselves that preventing drug abuse should and the lives lost from that is number one. And if they have to make some compromises with their own personal beliefs and ethics, that's a price worth paying.
Well, so now I'm not even sure if 6630507 is still active as a as a patent anymore.
Well, in any case, sorry, I lost you.
That's okay. Go ahead, Dave. You got to turn your camera.
Zoom back here.
Your camera needs to be turned. There we go.
Oh, there we go.
If you turn it sideways again, that would be great.
Right.
Okay,
Right.
beautiful.
In any case, those are very vague, non-specific use patents. They're not the only one. GW has a similar patent on, quote, cannabinoids for cancer treatment, and they're very broad, and they don't specify what cannabinoids are to be used for what. And cancer, you know, is a very broad category of illnesses that range from origin, cell type, et cetera, and genetics. So the validity of those patents depend on people coming up with specific data on actual efficacy of specific cannabinoids, and that's very difficult to do until the status of cannabis and any substance, any plant or substance containing more than 0.3% THC.
I wonder how they arrived at that particular percentage. Was it dartboard, do you think, or do you think it was something else? Did they try to figure out how much would get us high and then go below that? I mean, what's their, it's just to mess with us, I think, is what it really is.
If you ask people in the FDA and so forth, you can't get a straight answer about that. But of course, you can't get a straight answer from the FDA nowadays about anything controversial, because there's an acting director who's pretty much been silenced because of her allowing the approval of a drug for Alzheimer's that the advisory committee universally said had no clinical value. And the Biden administration is still not being explicit at all about what they intend to do in terms of reclassification, prohibition, and so forth.
What is your experience and your thoughts about using cannabis to get off of opioids?
Oh, I personally have a personal experience, not to get off, but to treat pain.
Okay.
Because even though my research and clinical experience made me an advocate, it wasn't until about 5 years ago when I developed thoracic output syndrome because of the collapse of two discs in my thoracic spine. And I went to, and a friend gave me brownies that he made from already vaped cannabis. Extracted the whatever was left in it from, and miraculously took away the pain for 4 hours. So when I went to see my primary doctor to start the process of getting a diagnosis and treatment, first thing he said was, "You obviously have thoracic outlook syndrome, but don't ask me for a prescription for opioids," because it was the height of the kind of panic over doctors being blamed for the opioid epidemic. I said, "No, I don't need a prescription. A friend of mine makes brownies. He's teaching me how to make them myself." He said, "Well, don't ask me here's a gay doctor I've known for 40 years, since the beginning of the gay health movement. But I forgot that was kind of a conservative Greek Orthodox person. And he said, well, don't ask me for a medical cannabis recommendation. I think it's a big scam for stoners to get high.
Yes.
But he did the right thing. He referred me to an orthopedic rehabilitation doc who, when I told him this, said, wonderful. I have hundreds of patients who are doing what you're doing, or to get off their opioids. And here is the information for the clinic that I send all my patients to, because I can't do it, but here's where they write most of the prescriptions for cannabis, most of the recommendations for cannabis in Illinois. At the time, pain was not one of the conditions, but because of so many patients and clinicians using it and finding ways around, eventually there was a special amendment to the Illinois medical cannabis program that people with a pain diagnosis could go directly to a medical cannabis doctor or dispensary and get that without having to go through opioid treatment.
So, do you currently go to dispensaries for your medicine?
Yes. Yeah.
So how are the dispensaries in Illinois? Are you in Chicago or some outskirts?
Yeah, I'm in Chicago.
Okay,
yeah.
so what are they like?
We've had a real problem in Illinois because everything they've done supposedly to make it easier for social equity applicants to get in there and to diversify and create more competition in the cannabis business in Illinois has only played into the hands of the initial license holders who become monopolies. So you have a few multi-state operators like Cresco and True Leaf and so forth that own the majority of the dispensaries and also produce the majority of the products. And as they consolidate their hold over them, they reduce the diversity of the products, so they weren't so much supporting their competitors, and they kept the prices high. So when my last trip to Las Vegas, where they have a much more open system of competition and so forth, when I visited Planet 13, the price was like 1/3 what it is in Illinois per milligram for cannabis.
So for instance, if you're eating an edible, okay, what does it cost for like 50 milligrams? Have you figured that out yet? I mean, I like to go ahead.
Edibles are usually packaged in 100 milligram
Maximums.
things, total. I don't know if it's a maximum, but that's the usual thing. And each, say there'll be 10 edibles, so each one has 10 milligrams. So, and they cost between $30 and $40 each. So if you're saying 50, it's half of one, so it's $25. That's a lot of money if you need that on a regular basis.
Yeah. I'd like to pay less than 10 cents a milligram in an edible. Okay, I actually like it more around 7 or 6 cents a milligram.
Well, you can't get that in Illinois at a dispensary, that's for sure, and that's what keeps the gray market going. Right.
See, that's what the lawmakers don't understand. If they of course, now you guys are recreational now as well. So if they have exorbitant taxes, and they're just going to push people to the legacy market, as they call it. So what do you think has to happen let me ask you this: what do you think is going to happen to the medical aspect of the program in Illinois now that recreational adult use has happened? Because I've seen medical disappear in many other states, like suppositories, patches, capsules. They disappear. Those medical products.
They haven't disappeared, and the only thing good that they did in Illinois when recreational came is they said that yes, the original licensees will be the only ones able to expand into the recreational market until we get everything figured out for a new round of social equity applicants, because there were none in the first round. It all went to people who were politically connected or financially could afford, to apply and set up. So anyway, what was it? I lost my train
Well,
of thought.
that's okay. Well, aren't they now like opening up licenses again because of the scandal that recently happened in
Yeah, but
regard
they're
to
doing it all over again. I mean,
the same way?
After they finally, a year late, said, now we fix things and we're rewarding it, they got a lot of complaints that they still had made it impossible
Right.
for real legacy, for real social equity applicants. They did something really stupid. Even though it wasn't in the criteria for the current round of license applications, when they got so many that scored high on the existing criteria, they added new criteria. It didn't have to be just social equity or minority ownership; it had to be veteran majority ownership. So that switched the licensing order totally away from the Black and Latino communities.
Well,
at the same time, the year and a half delay means that social equity applicants who had to have real estate identified, had to have capital identified to go ahead. Many of them have exhausted those resources in the year and a half. So right now, I have I'm a fan of our mayor, and she has put in a thing in the city council. I don't know if it'll get passed, to relax the zoning rules so that social equity applicants will have a much easier time opening up in the city of Chicago than they currently do.
They certainly need to be more transparent. And of course, transparency is something that is missing in this industry a lot of the time. So we here in New Mexico, where I live in Santa Fe, in New Mexico, just legalized for adult use. So we've had medical for 13 years or so. But the transparency, it's politics just get involved, and it's about money and me and it's just really, really horrible. So
I might want to just say I'm a real fan of Santa Fe. And,
excellent.
My younger sister did her nursing training in Albuquerque, and then lived in Santa Fe for a long time. Now she lives in Santa Cruz. So I got very familiar with that area, and it's really a wonderful place to be.
Yeah, it is wonderful here, and we're hoping that the rollout of the adult use market will not affect what's happening here with our medical, except for most of the medical people in this state were treading water until adult use came in a couple months ago. And so we're going to see who wants to be a medical provider or not, because New Mexico did a very smart thing. They opened up a discount license for people that want to be medical only. They can get lower fees, lower plant fees if they want to be medical. And that's the first time that I know of that micro licenses or discounted licenses in a state going adult is encouraging people to go into the medical industry. So we're going to see.
Well, that reminds me of what I was trying to say before.
Good.
They didn't do that in Illinois, but what they did do was make those initially medical and now dual primary license holders reserve their products for medical patients. And so when people were lining up on January 1st to buy recreational, they would only sell to the point where they had still enough to serve their medical patients.
I believe,
so that's the only good thing they did.
Yeah, I believe New Mexico is holding 20%. Okay, and of course we've had shortages in our medical all along. We had low plant counts and so forth. Are you aware of plant counts in Illinois, or is it unlimited for the vertically integrated entities?
I don't think that they base anything on plant counts, but they the current restricted supply and monopoly system means that whatever they can produce and get into a form sellable to the general public, they will do. And there's no reason to waste money on doing medical research or determining, developing better medical products.
So, part of the problem is when you just mentioned that the edibles are in 10 milligram portions. Okay, that's not good for medical people. Okay, because there's people, as you probably know, having back pain and so forth. You might need 50 or even 100 milligrams at one time. Are you going to sit there and eat 10, like a whole chocolate bar? That's not real medical. Okay, are there plenty of capsules, just canna capsules that you can get at these dispensaries that don't have sugar and all that other stuff in it? Are they making those products?
I'm not really not aware of those products. I think the closest we get to that are some of these beverage concentrates that you can, you
but
can
that's
dose out yourself.
Yeah, but
you're
that's still
you're still going to use half a bottle that
Yeah.
costs $30.
And that's still
per
not
dose.
and that's still not full extract cannabis oil. Okay, that's like distillate. A lot of the cannabinoids are taken out of it. So,
Right.
At least here in New Mexico, they do sell cannabis capsules with oil in them that are measured out. They could be 25 milligrams or 50 or whatever. Using the correct formula and mathematics. That's the real medicine. Okay, if you have to,
They do sell RSO, Rick Simpson oil,
Okay,
in my dispensary.
are they
But
doing
again, it's very expensive. If you wanted to use those kinds of doses, you're talking about hundreds of dollars
for
a
one
day.
for 1 gram? $100?
Yeah.
Wow, that's horrible. I mean, there it's like here it's anywhere from $35 to $50 for a gram of I call it FICO, full extra cannabis oil, RSO. Rick Simpson is the one that sort of brought that into the public, but it's really not a good term for it, actually. When he was making it, he was using naphtha, and I don't think you want to eat naphtha, that's left over in cannabis. So hopefully, some of the dispensaries will start making medical products, like patches and suppositories. That's one of the most popular medical products you can have.
Well, that's only going to happen if there's more competition, and that things like you talked about, discounting the cost for boutique, or we call here, smaller, these new smaller social equity applicants to enter the market and survive.
So
don't forget, I always say there's two ways to approach the business of medical cannabis: as a compassion that comes from the whole plant, which is what I believe in, or as for money. And when people would approach me to consult on their project, and the question I would ask them, I look at their background and see they're from finance or real estate. I said, why do you want to get into this field? If all I saw was dollar signs, in their eyes, I would immediately say, I think you have the wrong person, but I can give you other people to talk to.
Mm-hmm. Well, that's really commendable of you to do that. I mean, you're a physician. It's let's do no harm first, right?
Right.
But
I'm not going to say that all physicians are motivated by compassion, unfortunately.
Well, I mean,
especially in this day and age.
That's why they wrote a lot of opioids over the years, because they were getting perks from the manufacturers. I mean, obviously that's what was going on.
Right. And academics, where I come from, we're like among the most resistant to this, because we always felt, there aren't too many perks in academia. We're not doing it for the money. We're doing it because we want to, help people and advance, the science. But when the drug companies came along with nice things like trips to Bermuda and as part of a conference on their drug and so forth, who was to say that was a bad thing to do until it became clear that this was being used to promote off-label marketing of things.
They weren't exactly offering trips to Jamaica, were they?
No,
because that's where the real medicine is. So, in researching and just learning about cannabis, I don't know what your history was with it when you were younger, as a child, not a child, but as a young adult. But what is the biggest surprise that you've found over the years of studying cannabinoids?
That given the pervasiveness and plural effects of the endocannabinoid system, it's still not taught in healthcare curriculums, except in a few places. Now that's changing, but
is it being done in Illinois in any institutions?
There's one out of downstate branch of the University of Illinois that has a training, a master's program, because they also have an agricultural school there. But there's efforts to develop a statewide and Chicago-centered medical cannabis research consortium now. But that's still in the earlier stages.
How's your experience with the cannabinoid CBD?
Well, I use it for sleep. There are people who claim that it helps for pain, although my main interest is in the known effects of THC on disrupting the integration of pain signals to the brain, so that the individual is aware of them. That's how THC works. That's clearly established, and it does that without making the changes in the brain architecture that opioids do, that persist beyond, even after you've gotten off the opioids, you still have cravings because of those brain architectural changes that Dr. Volkov, pioneered finding. So, that's part of her, that's part of her shtick, that, any drug that will cause the synaptic simplification and snipping is a very serious drug. But when it comes to cannabis, you can't see that, because, as she said quite a few years ago, when she was hauled before the joint congressional board that was considering the various descheduling and ending of prohibition legislation that was before them at the time. And they kept asking her, what evidence do you have about the long-term safety and efficacy of cannabis? She said, none. And they said, well, if you missed an opportunity, yes, we missed an opportunity. But I would have expected that after that very well publicized and somewhat embarrassing, I would think, testimony before Congress, that she would have made an effort to reorient her institute to be more favorable to therapeutic research. But unfortunately, the power of the Office of Drug Control Policy on down to enforce the party line of prohibition is greater than any one individual.
So the FDA, has granted GW Pharmaceuticals a license for both their CBD product and their THC.
Right, but first they made GW take out all traces of THC from the product. So the Epidiolex that's sold in the United States is not the same as GW sells elsewhere. Elsewhere, it is a full extract of their high CBD, low THC strain. The United States, the THC has all been removed. And the argument that they made, and the principal scientist at GW at the time was against this, but he had no choice in the matter, was that we don't know enough about the toxicity of THC in children. And so if it's in the product, and it gets through testing, it'll be classified Schedule 1, and then doctors won't be able to prescribe it to the children who need it. Right. So under that basis, they made a special, not full spectrum extract based Epidiolex in the United States. And many parents find that their kids do better on their own or someone else's donated
balance
full spectrum oil.
Right, with a balance of CBD and THC together.
Right.
Okay.
Right.
Now, doesn't GW have a Sativex?
Right, but that's not licensed in the United States because they never got approval for doing studies here.
Now, one of the things that really screwed things up about GW is that now that CBD is in an approved medicine, there's laws about and rules about putting it into food, because you're not allowed to put a drug into food. So that's screwing things up. However, the workaround is that several states, like Colorado first and New Mexico and probably some others, have their own law about hemp and CBD in food. As far as topically, CBD for myself personally, this is anecdotal, has helped with, I'm trying to see if I have one here, has helped with pain. Okay. This is like a roll on. Okay.
Mm-hmm.
And if my shoulder hurts or something, or my hip or my side, it really does help. And the other thing that, as far as pain is concerned or sleep, I've tried using it for sleep, and even like a lot of CBN, and the CBN helps a little. The CBD doesn't help me personally sleep, but again, as you know, Doc, cannabinoids just react differently in everybody. What's good for one person is not the same for everybody else.
And that's a problem in research, because you can't say, for example, this is going to be the standard dose of this, which is what most pharmaceutical science is based on. So we talk about individualized medicine a lot.
Mm-hmm.
Okay. And I look at pioneers like Alan Frankel. I don't know if you've had him on the program.
I haven't, but he's in California, where I lived for 30 years in LA. So I know who he is very well. Don't know him personally.
So they pioneered, titrating individual cannabinoid concentrates, or, and to get to the optimal dose. So now I know the one thing that NIDA is going forward on is working with several of the cannabinoid medicine specialty organizations, especially the Society for Cannabis Clinicians, or SCC, which you're probably familiar with.
Mm-hmm.
It's based in California, to establish through their membership what is a, quote, standard dose. But even there, it's like standard dose for what? For pain, what type of pain, all kinds of other things. So it's very hard. And that's why, like everything in medicine, it's not just science, it's an art too, also.
Oh, absolutely. And dosage, everybody, is the most important thing in cannabis, and introducing someone new to cannabis and cannabinoids. So have you had experience introducing someone to use cannabis as medicine when they've never had it in their body before? And what is your experience with that, and how do you do that?
Well, it's a real problem. Mm-hmm. Because many people have tried it on their own and had a bad reaction, because if you have never used it before, you're going to be very sensitive to the side effects. And although they're not life-threatening like the side effects of opioid use, they are, if you eat too many edibles or you take too much THC, you're going to feel uncomfortable, and it's going to take a long time to go away. And so,
well, the point is, when a new person first tries cannabis, THC, they need to try such a very small. low dose, because if they have a bad I don't want to call it reaction, a bad effect. Okay. Reaction sounds negative, but the effect, for most people is good. But if you have a bad effect the first time, you'll never go back to that again.
Exactly.
Okay.
Exactly.
So it's like, I always tell people, take one puff of a joint, if you never had it before, and put it down. Wait 20 minutes. Wait 20 minutes.
And the advice that people like Dr. Frankel or Dr. Bierman make in their articles about the practice of cannabinoid medicine is always start low and gradually titrate to the best maximum effect.
And that doesn't mean
that's a labor and time intensive effort.
That
and
doesn't
most
mean
doctors don't have the time for that.
That doesn't mean the same day. When people take an edible and an hour later they don't feel anything, the biggest mistake in the world is to repeat it. Take another gummy or whatever, and that's when you get in trouble. So I had someone that an older person that was in the medical cannabis program here that was suffering from mild cognitive impairment. As you know, can move on to dementia and so forth. And I started them on like 1 milligram of a hard candy that they could just put under their and just suck it, okay, and dissolve it in their mouth, and then watch them to see how they were doing on that first day, and then talk to them, and then the next day maybe it was 2 milligrams, but then finally work them up to like 35 milligrams a day, and the agitation went away. People with dementia and so forth, they get a little agitated at everything, and sort of is a calming effect. And who knows what the cannabinoids are going to be doing for Alzheimer's in the next few years. It was mentioned in 6630507, the patent by the U.S. Alzheimer's. Yeah. All those things were mentioned. So to me, it's really exciting that now that all these states have medical and adult use is here in a lot of states, and we're over that hump. And again,
right. So let me stop you there.
Yeah.
What you described is kind of like the ideal way to approach it. But think about how impractical that is in modern day practice of medicine, where you're given 15 minutes with the patient,
Yeah. Oh, yeah.
And you have to make, very specific changes in them. If they're not responding, you have to in that 15 minutes, decide what is your next thing you're going to try and so forth. You can't be having them coming back to your office each day for trial titration up. That's not how the practice of medicine works. So first of all, we have to start thinking about other healthcare provider who, like nurses and so forth, who can, devote the time and effort to doing this, and make sure that they're included in it.
Yeah. There are great organizations, nurses. A friend of mine, Heather Manna Sobel, she's involved with the nurses organization. They help educate other nurses and so forth. This is going to be a thing. Cannabis coaches, people that have the experience and can help someone titrate like that. You're absolutely right. Physicians cannot do that.
But organized medicine is still against that, because that's where they're drawing the battle line, is allowing other paraprofessional groups to prescribe without having a medical training. And CBD is not a totally negative free substance. You can have interactions that are
I hear there could be adverse interactions with some other pharmaceutical drugs that are metabolized through that amplifies the effect of, let's say, blood pressure medicine, I believe is one of them, which means that the dosage that you're taking of your blood pressure medicine could be amplified and be too much for you and cause an interaction. So that needs to be worked out, and I think that we know about it, and it's up to you have to tell your doctors. Again, the doctors and nurses need to be educated. They weren't taught endocannabinoid system, most of them, 99% of them, because it's only been the last few years. And lawmakers.
But what they were taught was, if they do write a lot of recommendations, and the DEA will come after their license, or the state board will come after their license. And that's why these organizations were set up. We started the American Academy of Cannabinoid Medicine because so many doctors in California were being threatened with the loss of their licenses.
Right.
So we felt there needed to be an organization that had clear therapeutic recommendations, taught doctors how to keep the right records so that they would survive a state DEA or state medical board audit and so forth. But we've evolved past that. But still, the problem is trying to get all the doctors that are specializing in this and seeing patients and observing their responses and so forth, and experimenting with specific, cannabinoids in specific conditions, to use standardized assessment measures so we can combine that data and really get, the kind of large scale data with diverse patient populations, so we can look at what the best and least harmful treatments are, and what are the most effective ways to treat pain or cancer or a certain whatever. It is what has been my passion for the last 12 years. Trying to get a bunch of doctors to agree on anything is kind of like
Yes.
herding cats, if you know
Yes.
that.
Okay. So because you've been in the around this industry for so long, did you get a chance to speak with Dr. Lester Grinspin?
Oh, I knew Lester very well, and
Because he
I
was
always
so
tell
early. He was so
I always
early.
tell this one story that
Please.
in his original book, rediscovering marijuana, rediscovered. He said that that was published in 1971, and he said it probably will take 10 years to reintegrate cannabis into the medical, because his point was it had been part of medical
Oh, yes.
practice until Anslinger came along.
Right,
and
1937.
made a poster
Right.
for the war on drugs. And then the editor of the New England Journal of Medicine, in reviewing his book, took him to task. It's 10 years. Why so long? It's so clear.
Wow.
Wow. Which should be immediately. And here we are 50 years later. In fact, his son, Peter, who's also a physician and medical cannabis specialist, held an 50th anniversary
Of the book?
conference for the publication of his book. And
Wow.
I told this story at that conference, that here we are 50 years later, and it's still a Schedule I plant.
Well, he got to be around for a pretty good long time. He has a strain named after him, and he is such a pioneer to be so vocal and come out in 1971 to do that. It's quite amazing. With the 4 or 5 minutes we have left, what would you like to talk about that we haven't hit on today?
Well, that I really think that we can. I've waited long enough to see the kind of changes that are necessary to do the kind of research that my colleagues are asking for, and I really feel it's time that we say enough is enough. We know the unintended or inadvertent costs of these policies is enormous loss of mostly Black, Indigenous, and other marginalized lives, not to mention the mass incarceration system that's been built up around to support this, that destroys the lives of young Black men and women in the United States at an enormous rate. So we're talking hundreds of thousands of lives lost, and we have to start to balance that against those lingering concerns people have about the safety and efficacy of these drugs as we accumulate so much evidence. Maybe not in one huge pharmaceutically sponsored study, but in massive numbers of practice-based and even some placebo-controlled studies that have been done in other parts of the world.
So how can people get a hold of you if they would like to reach out and speak with you? I know that you're on some shows on Clubhouse and so forth from time to time.
Yeah, I've cut back a lot because I'm dealing with some personal health issues right now. But the best way is by email. My main email is BIG, then David, and my last name, O2@gmail.com. I'm not on Twitter. I'm not on Instagram.
Okay, well, you're on Medical Marijuana Radio today, and I really appreciate that. And I hope to have you back again, to talk more about maybe some new discoveries and about maybe the new medical cannabis industry that will happen out of all the acceptance that this really is a medicine. So, Dr. David Ostrow,
I hope you're right. I hope you're right.
I hope so too. Thank you.
But I always say, we have a window that could close, because as you've seen in some states that have moved ahead with recreational without protecting medical gets shafted, and people say, well, why should I bother going for a medical recommendation and license, spend that money and time when I can just go and buy it?
Right. Well, one of the reasons is the massive taxes on adult use and in medical. We have no tax here in New Mexico, and there should be no tax on medicine. You don't get taxed at Walgreens, and CVS, so there should be no tax on medical cannabis. So, Dr. David Ostrow.
But what they're doing in Michigan is very interesting. They just gave $12.5 million to MAPS to support cannabis therapeutic research for PTSD and veterans. And they'll be using strong THC concentrated medication from just dispensaries in the states where they do the studies. So that is one way that we're going to be moving forward here.
Thank you, David. I really appreciate your time, and your passion is fantastic. Thank you so much. I appreciate your expertise.
Thank you for having me. I
My pleasure.
appreciate these discussions.
We'll be right back after this. Thanks, David.
This is the Medical Marijuana Radio Show with Larry Love.
Well, I want to thank David very much. I also want to thank my two radio mentors, both with the initials HS. Thank you for your inspiration. Be back next week with another great guest. And don't forget my Friday and Saturday night show on Clubhouse, midnight on the East, 9 p.m. on the West Coast. We'll be back next time. Peace and love, everybody. Peace and love.